Hey team, so today we're going to talk about the FAST exam, so the point of care ultrasound exam that you will come to know and love. I know that some of you have already had experience performing the FAST and learning a little bit about it, but we are going to talk about a little more in depth today. First, we're going to start with a couple of cases. So case one, you have a 28-year-old male that comes in with hypotension following a motorcycle collision. Vital signs are given, respiratory rate is 22, blood pressure is 82/49, and pulse is 120. He's satting normally 96% on room air. You do your physical exam. You note that the airway is intact, he has breath sounds bilaterally, and a right lower extremity deformity. GCS is 13. So what do you want to do with this patient? How do you want to rapidly assess this patient for his cause of hypotension? Our second case is a 26-year-old female who presents with a syncopal episode. On review of systems and obtaining her history, you get that her last menstrual period was 8 weeks ago. Her vital signs are given as well. You'll note that she is a little hypotensive, 86/40, and pretty tachycardic with a pulse of 120. On physical exam, you note that she has tenderness across bilateral lower quadrants on her abdominal exam. So what's your differential here? And given that she is pretty tachycardic and hypotensive, are there any exams you could do at the bedside to quickly establish a plan of care for her? So now we're going to talk about the FAST exam. So FAST stands for Focused Assessment with Sonography and Trauma. EFAST is your extended FAST exam. However, we use the principles of the FAST exam not just for trauma now, but to look for other causes of hypotension, including free fluid in the abdomen as part of the RUSH exam, which is rapid ultrasound for shock and hypotension, and as part of looking for like a tension pneumothorax as a cause of hypotension. So what's the literature on this? We have the sensitivity as 62 to 96% and specificity of 83 to 100%. Of course, this depends on the experience of the person performing the exam. It decreases the CT use, it decreases time to the operating room, length of stay, and complications, and it's been part of the ATLS algorithm since 1997. If you have a positive FAST, you're done. If they are stable, you go to CT. If you're unstable, to the OR, but definitely not going home. If you have a negative result, you may still miss injury or fluid, so correlate clinically, which means you need to do a good physical exam with your suspicion of injury. Some patients can go home. They might be observed with serial FAST exams, or if they're having a lot of abdominal tenderness, move on to CT. It all depends on how your patient is presenting. What about in pediatrics? It's tough to study the FAST exam in kids. Usually they do pretty well and have no injury, so all of the studies are pretty low powered. The sensitivity and specificity is tough to evaluate as each study defines a true positive and a true negative differently. Some compare the FAST to any amount of free fluid on CT, even if it's not due to injury and only physiologic fluid. Some compare FAST results to whether the patient needed admission or operative intervention, and others do it somewhere in between the two. In pediatrics, literature has quoted a sensitivity of 21 to 98% for the FAST exam and a specificity of 60 to 100%. Just be aware of some of the pitfalls in relying on the FAST exam for your pediatric patients. So what are the indications for the FAST exam? The FAST exam does not localize your injury, it's just a screening exam for intraperitoneal free fluid. So it can miss hollow, viscous, and retroperitoneal injuries. The minimum volume for ultrasound detection of free fluid is 150 to 200 cc's in the pelvis, 200 to 250 for all FAST views. Injuries that do not cause free fluid may not show anything on the FAST exam. Injuries that cause a retroperitoneal bleed or retroperitoneal free fluid are not going to cause a positive FAST exam. So we do this to look for free fluid in the peritoneum, free fluid in the thorax, free fluid in the pericardium, and with the EFAST, we also look for a pneumothorax. What are the probes that we use? So Remember this from physics. So we have our phased array, which is a low frequency probe, which is great for looking for fluid in the abdomen and around the heart. We also have our linear probe, which is the high frequency probe. That's going to be terrible, absolutely terrible for looking in the abdomen, but it's great to look for lung sliding. And the final one is our curvilinear probe. This is a low frequency probe, so it can look for free fluid in the abdomen. It can look for fluid around the heart, and it can also look for lung sliding. So you can use these two for looking in the abdomen. And here are our views. So what are the views that we want? We want Morison's pouch, or your perihepatic view, our pericardial view, parasplenic view, and our retrovesicular or bladder views. So let's go through these right quick. For the Morison's pouch view, we want to position our probe in the mid-axillary line below the costal margin with the indicator or probe marker towards the patient's head. What we're really getting is a coronal view, slicing the patient from right to left with a CT view. If we're looking here, let's orient to what we're seeing. We should be seeing the liver in green, then the kidney. We're looking at Morison's pouch, so that space between the liver and the right kidney, and our diaphragm right here. We are also seeing our spine at the very bottom of the screen. So where are we looking? We're looking above the diaphragm, we're looking below the diaphragm, we're looking in Morison's pouch, which is the most critical here, then inferior pole of the kidney and the tip of the liver. So right here we can see the right kidney, the liver. Morison's pouch is that potential space between the right kidney and the liver. We want to make sure that we're looking down towards the inferior pole of the kidney, which is on the right side of the screen, and then the tip of the liver. See, always fan through as you are assessing Morison's pouch. So if you watch this video carefully, you want to fan through and look for fluid between the kidney and the liver. You can see as we fan through, we're starting to see an anechoic or black line appear in Morison's pouch, so right between the kidney and the liver. If we look a little closer, can you see that right there? Thank you, Radiology Arrow, for coming in, but we're seeing that little bit of fluid. So initially it looks negative, but now as we fan through, we see that this view is in fact a positive Morison's pouch view. Again, fan through the entire right upper quadrant. You are looking at one small little slice when you are fanning through with your ultrasound, so you want to make sure that you fan through the entire area so as to not miss small amounts of fluid. Now as we're scanning from the kidney and Morison's pouch upwards or a little more towards the coronal direction, we are seeing fluid above the diaphragm. We're seeing the spine extend above the diaphragm, and so we're seeing a little bit of a pleural effusion. And as we're scanning through again, this is the same patient, and this is why it's so important to fan through the kidney. So as we look at the kidney right there, we're seeing no fluid, but as we continue to fan through, we are seeing fluid outlining the kidney, the liver, and Morison's pouch. Next, we move on to our parasplenic view. So this is a view we're looking namely between the spleen and the diaphragm. So this is the opposite of the Morison's pouch view or right upper quadrant view. We're still going to have the probe marker to the head, but we're on the patient's left side. Our probe is positioned way more posterior in our posterior axillary line and a bit more superior, so above the costal margin. You have to go posterior to the posterior axillary line to avoid the stomach. We have a much smaller acoustic window with the spleen when compared to the kidney. So when I'm doing this view, I'm literally reaching around the patient, placing my hand and the probe on the bed to obtain that coronal view, slicing the patient from left to right. I can then adjust my hand by fanning to optimize my image. So what we should see, we're seeing the spleen here, then the kidney. We want to look for the interface between the spleen and the kidney, and very importantly, between the spleen and the diaphragm. We're seeing the spine here as well, so always make sure you're looking through. We start looking above the diaphragm, but below the diaphragm, so between the diaphragm and the spleen, is the most important area that we're going to look for, and we have to see that interface because that's where we are going to see fluid first. And then we look to the splenorenal recess. So right here we're seeing our left upper quadrant or parasplenic view. We're seeing the kidney. We should be seeing spleen and diaphragm at the very beginning of the clip, and watch it come through. So this is our next view. It's still a parasplenic view, but we're seeing that fluid wrapping around the spleen just below the diaphragm in that right upper quadrant view. Can everybody see that? Make sure that you're able to see and appreciate why it's so important to get that particular view. Then we go on to our retrovesicular or bladder views. So we do both a transverse view and a sagittal view in the retrovesicular view. So your transverse view is just above the pubic symphysis, way below the umbilicus, and you're angling the probe to the patient's feet. You have your probe marker in the transverse view pointed to the patient's right. In the sagittal view, you rotate 90 degrees clockwise, so you have the probe marker pointing towards the patient's head. When we're obtaining a pelvic transverse view, this is an axial cut. You're seeing the bladder and you're seeing uterus or prostate behind this. Fluid is going to collect behind the bladder or behind the uterus in the pouch of Douglas, but can spill between the uterus and the bladder. In men, it's usually directly behind the bladder. In our sagittal view, remember the bladder is going to be closest to the screen. The uterus is more posterior, so furthest away from the screen, and more cephalad. The vaginal stripe is directly behind the uterus. Fluid's going to collect behind the bladder or behind the uterus in the pouch of Douglas, but can spill between the uterus and bladder. In men, usually directly behind the bladder. Here's an example of what we want to see when performing the FAST exam in the bladder views. You want to see the transverse and the sagittal views. So here we have a female bladder view, transverse, and we can see in the sagittal view, we can clearly see the uterus as well. New blood is going to be anechoic on the FAST exam. Ascites is also anechoic, which is impossible to differentiate. Clotted blood is echogenic, or it has varying shades of gray. So if you look here, it almost looks like there are two bladders, which you shouldn't have two bladders. So this is a positive FAST in the transverse view. In the sagittal view, we can also see fluid behind the bladder as well. The key of getting a transverse view is to remember that part of the bladder is retroperitoneal and part is intraperitoneal. So having that sagittal view, make sure that you do not miss any fluid on your transverse view. So looking closely, here's another sagittal view. Look closely, it's almost easy to miss this free fluid right here if the gain is too high or there's too much posterior acoustic enhancement, so you may need to make some adjustments. Some tips for the pelvic view are to turn down the far field gain, so adjust your time gain compensation. You need to make sure you have plenty of depth, a full bladder, and watch out for seminal vesicles. Now we're going to talk about the cardiac view. This should be a review because we just went over all of the cardiac lectures and cardiac views, but cardiac is an important part of the FAST exam. So for the FAST exam, we do either a subxiphoid or a parasternal long axis to look for free fluid in the pericardial space. I want you to look here and see the fluid wrapping around the heart in our pericardial space. Yikes. Now we're in a subcostal view. We're seeing liver at the top of the screen, the heart right beneath with the right ventricle and the left ventricle easily identified. No fluid surrounding this heart. That looks great. But then we go on compared to this heart. So same view, we're seeing liver at the very top of the screen, we're seeing right ventricle, we're seeing left ventricle, and we are seeing free fluid wrapping around the heart here. Remember that the size of the effusion matters less than the rate of accumulation. A traumatic pericardial effusion that accumulates rapidly can be very small but extremely dangerous compared to a large pericardial effusion that's been accumulating over months and months and months. So some tips for your subxiphoid view. You want to hold the probe in the palm of your hand so you can flatten it out and have a flat angle to assess the patient's heart. You want to go just to the right of midline and aim the probe to the patient's head. This helps get rid of the stomach bubble, which can impede your view. Make sure that you have plenty of depth for your subxiphoid view. You can have the patient take a deep breath and hold it, and always switch to a parasternal long axis if the subxiphoid or subcostal is too painful or too difficult. So what are some false positives? Here we're seeing the double-line sign in Morison's pouch. So we're seeing it's paranephric fat that's wrapping around with your fascia plane. So we want to make sure that we're looking outside of those fascial planes that surround the kidney. Here in our parasplenic window, we see a huge stomach bubble right there. So we want to make sure that we're not angling too anteriorly with our probe and getting that stomach bubble. Some ways to avoid this are to make sure that you're fanning through the spleen, and you might want to slide your probe from, or sweep actually, from your posterior axillary line towards your mid-axillary line while you are fanning the probe to see if we can get rid of that stomach bubble or gastric bubble and bring into view a nice crisp spleen diaphragm interface. Now what about that one? That looks like a whole lot of fluid right behind the bladder, but it's actually a large ovarian cyst. So note the smooth walls of the cysts that are not outlining the bladder or bowel. So free fluid in the pelvis will have sharp edges as it starts to outline bowel. This one is nice, round, smooth, and so that is an ovarian cyst. So in conclusion, we have reviewed the FAST exam, the 4 views of the FAST exam, so your Morison's pouch or right upper quadrant, your parasplenic, your retrovesicular, and your cardiac views. Don't forget about thoracic with your eFAST exam. FAST is great not just for a trauma patient, but for any patient with undifferentiated shock or hypotension. If you have any questions, please email me at the email address seen here, and good luck scanning.